Sola, can I ask you this question I've got now from Mrs. B?
Sure.
She's 27. Her anxiety is because she's had 4 miscarriages now, one after the other. Now, every time she falls pregnant, quite easily, she loses the pregnancy around 8-10 weeks. Now, she feels very judged by her family and she feels a failure herself. This is exactly what she's written, and she doesn't know what she should do next.
I sympathize with Mrs. B because miscarriage is a very tragic outcome regardless of the gestation. We as human beings are very poor reproducers. We would expect 1 in 8 pregnancies to miscarry. It is believed that it's nature's way of correcting abnormalities, because when you look at majority of these miscarriages, it's because the pregnancies have not been properly formed.
Well, you can imagine somebody having it over and over and over again.
In terms of the first one miscarriage, one attributes it to chance. And certainly by the time you have a second one, obviously there's always a lot of psychological overlay as to what exactly is going on. By the time you get to the third one, then you start making a diagnosis, a gynecological diagnosis of recurrent miscarriages. Recurrent miscarriages they're not as common as spontaneous miscarriage that occurs just once. In terms of Mrs. B, there are a lot of issues here. It's not only gynecological, because there's the perception of herself as a failure. There is the judgment or perceived judgment that she sees from her friends, her family, and I'm sure she has people, particularly at a place of work in her family, who are pregnant and been carried on to have successful outcomes. So in essence, she sees herself as a failure as well. Now, with regards to what can be done, and is there any hope for Mrs. B, the reassuring thing is, majority of times, we would expect 7 out of 10 women like Mrs. B to have a successful outcome.
True.
However, in terms of getting there, we need to be able to reassure Mrs. B that there are no underlying problems. And this sort of underlying problems will be, is it that Mrs. B herself has inherent conditions? Could it be that she has some abnormalities of her chromosomes or her genes? Is it that with her husband? Because you would expect she will contribute half of her genes, the husband will contribute half of their genes. They need to sort of marry up or align properly for them to have a normal baby. So in essence, we need to look into that. We need to look into the womb, which is going to be the receptacle for the pregnancy, as to is there any problem as to why this guest is not staying in the womb. So we need to ensure that that is fine. There is a condition called sticky blood, Shield syndrome, or antiphospholipid antibody syndrome. Whilst it sounds very exotic, majority of times we know that there are limitations in making the diagnosis, and there are variations between one laboratory or the other. It would be helpful if Mrs. B, general practitioner, would initiate this test to screen for antiphospholipid antibody syndrome, because it's a condition that can be treated and can be treated with something effectively with using something as simple as aspirin or using heparin injections. And lastly, there are conditions called thrombophilias, which makes your blood more clotable than usual. And in this case, it may be that Mrs. B needs to have injections to make her blood less clotable during the course of a pregnancy. Saying that though, depending on what is found, it is my hope that Mrs. B becomes pregnant and she's able to overcome that initial hurdle of 10 weeks. We know that majority of times, once you can identify fetal heart, 95% of the times the pregnancy will continue. Depending on what the underlying problem is, certainly we need to monitor that pregnancy quite carefully to make sure there are no untoward developments in the pregnancy, like a small baby or like actually losing baby during the course of the pregnancy. However, these are things that will need to be picked up by Mrs. B's local obstetrician once she becomes pregnant and the pregnancy is established.
True, I guess once she passes that first hurdle of the first few weeks,
Yes.
she will feel a lot more confident.
Yes.
And like you said, in 7 out of 10 women, there's that hope. And not to lose hope
Yes.
is the first step.
Yes. The other thing is there are some empirical treatment which different people do use for different reasons. Now, there are clinicians that will give somebody like Mrs. B injections containing the same hormones that the pregnancy produces to support the pregnancy in the initial phase. Does it work? It's difficult to say. There is evidence to say it works. There is evidence that doesn't support the fact that it works. And there is no evidence to say it's harmful. Now, it would have to be a decision that Mrs. B and her local clinician will have to make as to whether she wants to have it or not.
I see your point. In many instances, it's a very individualized decision as to what is right for that particular woman.
It is. It is. The other one, obviously, is the use of pessaries. We know that a lot of IVF units would prescribe pessaries in the first few weeks to support the pregnancy. In the days of old, it used to be prescribed. There seems to be a resurgence of the use of the pessaries now. Certainly, this is another one that she needs to discuss and be quite comfortable that this is something that she wants to use in the pregnancy.
Shall we leave it at that with wishing Mrs. B the very best in her next pregnancy?
Excellent. Thank you.
Thank you.